I'm going to go ahead and get started. So good afternoon, everybody. Welcome to today's National Neonatal POCUS Collaborative webinar. I'm Andrew Beverstock, and I will be your moderator today. Before we start, just some general housekeeping items to make note of. The chat is disabled for the audience, but the moderators may send out general announcements via the chat. Please use the Q&A feature to post questions. We will answer those during the Q&A panel session. This webinar is being recorded and will be uploaded to the collaborative website, which is neopocuscollab.com. Now onto our main talk. Our guest speakers today are Dr. Russ Horowitz and Dr. Monti Sharma. Dr. Russ Horowitz is the Director of Emergency and Critical Care Ultrasound at Ann and Robert H. Lurie's Children's Hospital of Chicago and an Associate Professor of Pediatrics and Medical Education at Northwestern University Feinberg School of Medicine. A national leader in point-of-care ultrasound, Dr. Horowitz developed and leads Lurie's hospital-wide POCUS program. Dr. Monti Sharma is an attending neonatologist and pediatric pulmonologist at Children's Nebraska in Omaha. He is also the director for neonatal POCUS at Children's Nebraska and has a specific research interest in lung POCUS for BPD. Like Dr. Horowitz, Dr. Sharma helped develop his hospital's credentialing and privileging system, as well as implementing a standardized workflow for using POCUS in the NICU. Dr. Horowitz and Dr. Sharma, please take it away.
Thanks very much, everybody. Even though the topic of credentialing isn't really the most necessarily the first thing that people think about when they think about point of care, it's probably one of the most common questions and topics that I get asked about. And I think Monti and I sort of end up engaging in this kind of discussion with people every time we teach. So I'd like to go a little bit through a standardized sort of plan, and then Monti's going to pick it up specifically for the Neo environment. So I'm going to share for you, and then let's just make sure that everybody can see what I'm doing here. All righty. Hopefully we could see everything. Yeah, Monti, everybody could see?
You're in the navigator view.
All right. Please hold. And let's do one more. Let's do one thing, and then we can see this one more time. How's that?
Excellent.
All righty. So the objectives, and we'll sort of flip between Monti and I a little bit to sort of reinforce some of these concepts, but we're going to talk and delineate the differences between credentialing and privileging, describe a system-wide approach, and then move specifically, how do we apply these in the NICU environment? So first, two main different distinctions. There's credentialing and privileging. Credentialing is, the way I think about it is, credentials are things that you learn, and privileging or privileges are things that you earn from your facility, and it's specific to your own hospital or hospital setting. So let's broaden back a little bit and just look at credentialing. What really, when people say, are you credentialed to do something, is, can you provide patient care? So based upon using the example of fellowship training, are you credentialed to do neonatology? And that's based upon the idea that to do neonatology, to graduate from a fellowship, you have to do 36 months plus 36 months of pediatrics. And included in that is inherent the idea that, can you do these particular processes? Do you know how to do history and physical and exam and the basic knowledge for neonatology? Now, as we think about that, there's different ways for people to kind of get credentialed in point of care. I'm going to talk about this a little bit and then broaden back out. So if you don't learn as part of your fellowship training, then there are other places that one can go. As an example, there are courses that are provided by some national groups like CHEST, Society of Critical Care Medicine, and the American Board of Pediatrics. Those courses are usually a day or 2 days. There's some didactic information, hands-on learning, and that's often where most of these end. CHEST and some commercially available courses allow people to gather that information, do hands-on training, and then follow that up with some image review that's directly obtained from the individual providers. That would mean that you capture those images, you store those images, and those get reviewed by an expert, and you go over those images. There's also commercially available courses and courses provided by different institutions and hospital systems in point of care. Privileging, in contrast, is what the hospital allows you to do. So here's my example. As an emergency medicine provider, I can do everything from history and physical to incision and drainage to open thoracotomy. Doesn't mean that I have to do those things. It just means that I'm allowed to do those. In contrast, I can't do an appendectomy. I might kind of know how those things are done, but the hospital says, nope, that's outside of what your privileges are. And you have to function within your privileges to essentially be covered by the hospital and for them to say you're working within what we deem that you're able to do. So how does one become privileged? Well, the privileging documents are designed and approved by the privileging or credentialing board at your hospital, often headed by some big person, usually like a chief medical officer. And there's two main pathways. There's a postgraduate pathway and a practice-based pathway. The POCUS training that one would get during fellowship allows people to get a postgraduate pathway. And what happens is when you finish your fellowship program director writes you a letter that goes to your new facility and allows you to do neonatology. Given that POCUS is not inherent to the training like it is in emergency medicine, which has had POCUS training for years and years, it often acts as a separate thing. So the fellowship director or the POCUS director in the institution or division or department writes you a separate letter. They say that you've had didactic training, hands-on training, and you've completed a certain number of images as stored. Often the hospital then requires a letter to be written and signed by the POCUS director and the person who oversaw those POCUS trainings. In contrast, for those people who didn't get it during their fellowship, or their fellowship was long ago, they can go through what's called the practice-based pathway. And I delineate these two ways so that people who didn't get training during their fellowship also can prove to the hospital that they have enough POCUS knowledge, so they should get privileges. In addition, these are the things that are delineated in our POCUS privileging pathway documents. And I think Monti is going to provide an example for you of those that gets written. So the POCUS director at the new facility says, how did this person gain their competency? How can we privilege this person? Did they learn it during fellowship? Or did they learn it based upon a practice-based pathway? That would be where you do a course. That course includes both didactics and image acquisition. And then you acquire a certain number of images. What number and in what different applications is up to the individual facility in which you are applying for privileges. Another example of how privileges can differ is let's talk about things like in general critical care. Those providers do all the critical care, but there might be some special people that do neurocritical care or some people who do ECMO care. So they would get a special line item that allows them to be the providers who do that. In the same way, we have our general surgeons, and then we have our surgeons that can use, let's say, the robot, or can use minimally invasive procedures. And those are separate privileges at certain institutions that individual providers can get based upon their experience, attendance at a course, or the fact that they got it during their training. So often people combine the idea of all POCUS processes, all POCUS applications. Some different groups will break them into separate parts. There'll be like a diagnostic part and a procedural part. What we've done at our institution is we've said for vascular access, which is inherent to basic privileging for critical care providers, is we say that people can do vascular access, including with the use of ultrasound guidance. That means that you can use it, but you don't have to, and that you're covered as part of your general privileges. Now, from the approach to privileging, if you're the person who's creating this document, we have a couple of different options as to how you do it, and different institutions have created their own design with their own logic. There's different ways. They are all inclusive, as an example. That's what we do at my facility, which means if you're POCUS privileged, you've met the credentials, and you can do POCUS for everything. That includes things like neonatal head, airway, thoracic, cardiac, and all the way down to things that wouldn't necessarily be applicable to your environment, but might be applicable to my environment, like appendicitis and intussusception. It means that you have the ability to do POCUS applications in children. Some different facilities will break it down into a basic and advanced privileging. The basic might be things like lung and cardiac and abdomen. Advanced might be things like head, small bowel obstruction, soft tissue, certain base procedures. Others go down individual applications. So they might say you can get privileged in cardiac, but that means that you've only met the criteria for cardiac. You can get privileged in lung. You can get privileged in abdomen. Each of these have their own good and bad sort of ways. Remember that if you're all inclusive, that means the hospital says you can do everything. And just like different people are good at different procedures, and we often ask for help from other types of providers or our friends, that means that you also have to respect the breadth that the privileges provide for you. I use myself as an example that I'm pretty good at EKGs, but I'm not great. If I have something that makes me a little bit confused or nervous, then I bring in my cardiology friends. In the same way, if you have all-inclusive privileges and you're doing a cardiac exam, but it seems a little funny, maybe that's the one that you have your cardiology friend evaluate, or you say, I can't interpret this image because there are some technical problems. If you do a basic and advanced, then recognize that you're going to have to delineate between who has basic privileges and who has advanced privileges. And that means the people who have advanced privileges can do both, but people who have basic privileges are only allowed to do a certain subset of POCUS applications. That means they can't make decisions on their advanced ones, even if they're able to acquire those pictures. If you do application-specific ones, and we're talking about things like billing, and I know that's separate from what we're talking about here today, but often sort of leaches into the conversation, then you have to make sure that people are only submitting exams for billing in those categories of applications that they are privileged to do. They might know how to do lung, but they haven't gotten their complete number or gotten privileged, then they can't record and bill for those procedures or those studies. Does that make sense, everybody? Monty, make sense to you? Great. Okay. In addition to acquiring the initial privileging, hospitals or hospital systems will then say there's ongoing performance evaluations. And that means that over the span of some number of years, and it might be 1 to 2, that the person has to provide and document evidence of performing a certain number of studies. What number of studies is determined based upon your facility. Some say 10 a year, some say 25 over the span of 2 years. Some will break it down by procedural and diagnostic, combine those together, and some will separate those two out. And there has to be a way for you to document that you've performed these procedures so that they can be retrieved and reviewed. The person who reviews those is usually someone who is either the division POCUS director, the department POCUS director, or the overall hospital or system-wide director. So I'd like to just mention a little bit, and Monty's going to bring it on a little bit better. When we're talking about how someone acquires privileges, there is likely some sort of privileging for POCUS at one's facility. That might be your hospital, your unit, your hospital system. There's often either system-wide POCUS director, the big boss, who works across all institutions in that hospital system, or there might be a person who is only for that hospital system. And that's the one who will then be able to sign off when people arrive or sign off when people acquire these new privileges. If you have a system-wide person or a division-wide person and you're trying to figure out how we get these privileges, then I encourage you to reach out to other divisions or departments within the hospital. Often emergency medicine will have one, particularly if you're working in a hospital that is more of a general adult hospital. There might be one specifically for OB because they use POCUS as part of their general practice. Anesthesia may very well have one because they use it for nerve blocks and procedural guidance. The other one might be adult critical care. So before people start reinventing the wheel and writing things from scratch, I encourage you to reach out to your credentialing department in your hospital, once again, often headed by the CMO, and say what exists, and then model it based upon those other areas of the hospital. If you happen to be building your own, then online there are specific documents that are written. The one that's really easy to describe and to retrieve is from the American College of Emergency Physicians, and they have delineated different types of POCUS applications and ways to write these so it makes sense and fits into traditional privileging documentation. Monti's going to pick it up from here and talk specifically about how the privileging will work in a NICU.
Thanks, Russ. Well, that made perfect sense to me because I basically leveraged everything Russ has talked about to work with my institution. And to kind of echo what Russ said, definitely leverage what already exists within your institution. So to identify those stakeholders. So with that, let me talk about what goes on in my unit. And I'm going to leverage Russ to be my slide mover. So let's take a model of a neonatologist in a high resource setting. So someone working in the United States. At my institution, we basically did what Russ has talked about. We said, hey, this guy has this plan for an entire institution. Why don't we try something similar? So we worked at the general institution level and then identified the stakeholders, right? Which for many of us is radiology and cardiology. We basically put them in the middle of this algorithm so that it made it seem like they were actually our bosses. That way they were getting insight and providing insight to us with what works within the scope and framework of the hospital. And within that, much like what Russ mentioned, that there were divisional champions or directors. Some of you remember from last time's webinar, Adib Adam, who's one of the ER providers where I worked. He's the director in the ER, I'm the director in the NICU, the hospital medicine group has its own director, and the PICU has its own director. All right, next slide. And for that, hit it one more time. What we all did is, if you hit it one more time, Russ, we came up with a general policy for the entire institution. In that little guideline, it basically defined what ultrasound was and what specifically the radiologist called limited ultrasound. We all know it's not limited, it's unlimited as far as its potential. But this is how they defined it, right? And what the purpose was and how it would change over time. Next slide. And just to really highlight it again, I think this slide is duplicated, so you can hit through it. What we then defined was, how do you get educated in this specific thing to obtain credentialing? Russ had mentioned two different models. There's the fellowship-based model and then the education, kind of the learn as you go system. This is for people who might already be in the institution and are now interested in learning point of care ultrasound or any other skill, right? It could be for learning how to do a brand new procedure using a robot. So this is what we defined within this document. It said, hey, look, you can either come with a program director letter, so someone like Russ writes you a letter, or you can have a letter from your division chief, or you can work within a mentorship model within the hospital, i.e. you are getting oversight from someone like emergency medicine. And in fact, that's kind of what I did. I provided them with lots and lots of letters from people like Russ and folks at other institutions to say, hey, look, I have been receiving mentorship. If you hit next. So that was the one big thing about it. It's flexible, right? There's all these different pathways to prove that you are receiving the education required, i.e. showing competency towards credentialing. Hit next one more time. And the other thing we built into this document was that it's dynamic. We understand that things will change over time, right? As more guidelines come out, as more literature comes out, there might be other pathways for credentialing. And again, if you go back to what Russ mentioned, credentialing is a lot of learning. It's what you have learned in your pathway towards what you have earned, which is privileging. So next slide. And then, of course, there's the maintenance of it. Russ mentioned that number 10. A lot of this is actually negotiation with the people that are the stakeholders. For my institution, cardiology and radiology felt like 25 would be a better number every 2 years to maintain your skill set. So we set that number as 25 for the entire institution. It doesn't matter if you're a hospitalist, if you're in urgent care working out in the community, in the emergency room, or the ICU. That number was set to 25 examinations and interpretations with QA. The people who say that yes, that we are assuring quality on this are the directors within each of those different branch points that you saw earlier. In addition to that, we highly encourage people to attend hands-on session. Part of it is that we host hands-on session within the entire institution. And then for procedures themselves, because a lot of them fall under core privileges, which I'll talk about in a couple of slides, we said, hey, you need to do at least 5 per year to maintain that. And again, a lot of this was negotiation with the hospital administrators, right? They felt they needed some sort of safeguard. And in that process, 5 was determined to be the number that, hey, if you've done 5 chest tubes, you can maintain privileges to do this, right? As a pulmonologist, to maintain my privileges for chest tube, I have to have 5 documented chest tubes. As a neonatologist, I don't need to do that, right? That is a part of our core privileges. Next slide. And then what we did was within the different departments, we modified it so that it fits our needs, right? What I need is going to be very different than what the emergency medicine department might need. I don't think Russ has seen a 23-weeker in the ER, and I have never seen a 3-year-old or 4-year-old in the NICU. Though, can that happen? I'm sure eventually it can. But at the moment, that is outside of the neonatal practice. So next slide. And so what we did was we looked at models across the world first. Well, in Europe, we know that lots of institutions use POCUS, right? A lot of our colleagues in Europe are well ahead of us. The Italians are so far ahead of us, I don't think we'll ever catch them. But that's because their models are different, right? How they get credentialing and privileging is different. In lots of those countries, neos are trained to be the primary sonographers, especially, for abdomen, for example. A lot of places in Eastern Europe, that is who does the abdominal ultrasounds. Head ultrasounds. Poland has a lot of great information on head ultrasounds done by neonatologists. We have lots of colleagues that are also cardiology trained. The problem is in the United States, most of our training at the neonatal level occurs at quaternary centers. Even if the majority of us go on to work at what would be considered a tertiary care center, i.e. a big delivery hospital without lots of subspecialists, our training occurs at these quaternary centers where these large stakeholders, radiology and cardiology, have quote unquote ownership over some of these things. Now, a lot of that requires kind of teasing out how to get them to be stakeholders and collaborators in this process for success. Next slide. The ER has been well ahead of us, right? As Russ mentioned, ACEP has had guidelines for a long, long time, which the emergency medicine groups in pediatrics have been able to emulate. The good thing for us as neonatologists is that they do provide a number, right? As far as, hey, you need to do this many scans to show that you are competent at doing it. And you initially need something like this because the hospital administrators, that's what they're really looking for is, hey, is there some sort of document that we can fall back on while evidence is growing? It's different at every hospital. At some places, hospital administrators are physicians. At other places, they are purely trained in business, right? So you have to work with these different stakeholders. Next slide. And so what we came up with then is what things are we going to need to obtain credentialing? One is a document that lists the number of scans performed, because ultimately the person saying, yes, you're credentialed will want to see it. or a letter stating competency and training. This is what we ended up doing initially because at the time there was no one that was credentialed. So we reached out to people that had trained us, people like Russ who wrote letters and said, hey, yes, this person can be trusted to do this. And then we came up with the credentialing pathway within our institution. It's that large document that you saw. So again, these are things like courses, going to courses at different parts of the country and coming back with a certificate that says, yes, I did 10 scans. What is the next step? And then taking away from those courses, references from those courses, people that you meet there. So I would highly encourage people to keep in touch with the people you meet at courses that you're doing across the country, and then doing structured images with other departments. Initially, radiology did some of our image reviews with us, and then they realized it was so boring and they should just trust us with it. Next slide. So let me take lung as an example, because, of course, I'm a pulmonologist. So we started out by saying, hey, look, lung fields, diaphragms, airways, like where do all of these fall within credentialing? And then we said, well, for procedures, you have to have those skills without ultrasound, right? So you're basically using ultrasound as a way to augment that procedure. Now, I know it's a little more complicated because that requires having that visual motor skill and incorporating those together. It's not just as simple as, oh, hey, I can do a chest tube and drain a pleural effusion without ultrasound. So of course, ultrasound will just make it easier. I think there is some truth to that, but remember that also requires now having an additional device, looking at a new screen and poking simultaneously. So that still requires the incorporation of a new skill set. It's not as simple as just augmenting that skill. Next slide. So then let's take a look at lung fields. Well, how many scans do you need, right? How many times can you scan the same individual? Is this an effusion or a pneumothorax? For us, if this was an advanced versus basic, we said, well, this is an easy thing. You can scan different patients. It's easy to get that number in. So we would say do between 10 and 25. I would highly implore people, though, to not use ranges. It gets really complicated for the hospital, and they will always pick the higher number. Next slide. For diaphragm, it's, is this a skill that's moderate or easy? In our hospital, we said you need to do 25 of these scans to be credentialed. And in that, you can look for the presence or absence on each side. You can look at symmetric movement bilaterally. You can use M mode for measurements, for thickness. And then again, as I mentioned, this is probably a moderate skill set. Next slide. And then airway. Well, for our hospital, this was a point of contention. We worked closely with our ICU folks, and they strongly felt that this is a difficult skill. And I would agree with that. And within that, the examples we gave is, well, it's probably easier to say, yes, it's in the trachea. No, it's not in the trachea. However, measuring distance to the carina isn't always reliable. And you definitely can't do the same intubated kid on ECMO 25 straight times. And so for us, this was a difficult skill set. Then it's who gets credentialed, right? And what I would propose is coming up with the same set of skills for fellows and NPs, but the one thing to consider is that their oversight body within your hospital might be different. For example, at my hospital, NPs are hired by the hospital. Physicians are hired through a foundation, which is the case in many states where physicians cannot be hired by the hospital itself. And then for attendings, is there an internal process, i.e. you have everything established, or can there be an external process? Can they go to courses, get mentorship outside of just people within your institution? Next slide. And so from that came this credentialing document. This is the NICU specific one. If you hit next one more time, Russ. And what you can see here is that we have different regions of the body that can be scanned, and then examples. This is not the limitations of what can be done, but really just examples of what kind of things people can do with the number of scans required. The one thing I want to highlight, if you go back one, is that we again left this to be dynamic. We could do cardiac evaluations that would eventually fall under functional neonatal echocardiography once the program was up and running, right? This didn't have to be things that could that were already being done that were then being formalized, but things that could then in the future be incorporated within this credentialing document. Next slide. This right here really helps for the individual. This is how you track what the individual is doing. And the way I see it, it's a log for you. It's how you track progress, and it becomes a personal portfolio and provides a report. And what this is a REDCap form. It lets you pick out where you were doing the scan, what your role is, the region that you were scanning, and what you did with it. This is mainly so, say a fellow does a bunch of scans and they're leaving the institution, God forbid, you can print something out that they can take with them. It's a lot easier to query REDCap than it is to query something like Epic. Next slide. Which is more, in my mind, for administrators, right? This is a log for the hospital because that is what they do for lots of different procedures. This is how they provide Joint Commission with a log of how many bronchoscopies someone has done, how many heart surgeries someone has done. It's easy to query. It's also easier then to provide quality assurance, right? You can more easily go within Epic and say, hey, run a report for me. And then for maintenance, right? Now what the maintenance person does for us is they run a report and they get all the scans that different individuals has done. Next slide. And so this creates a closed loop system with low provider effort. Exams aren't missed. They're always ordered because the machine requires an order for you to scan. QA is easy, and therefore the hospital is happy because in order to bill, you need some of these things. Next slide. Which then gets to privileging, which is something that you earn. Next slide. And so from a process standpoint, in most places, this is something reviewed by people in administrative roles. They might be physicians, MBAs, MPHs, whatever their roles are. They rely on an administrator who says, yes, the credentialing paperwork is filled out. Should we give this person privileges to practice, i.e. then will the institution's insurance protect them? And they review these during periodic meetings. So it's not like every single day, right? For us, they meet every 2 months. Who then signs off on your ability to practice. Next slide. And so I want to highlight that privileging is an initial process. It's not unique to just POCUS. It's the addition of any new privilege. Say you come up with a new robotic procedure or find a new robot that can do something cool, you will have to go through the same process. It's like a vetting process. It's oftentimes the pain the first person encounters for the long-term gains, right? And as you can see here, this is basically what the hospital said. Hey, look, I hereby request following additional privileges, which here is point of care ultrasound. And then you go through and fill this out. And again, get fancy documents from people like Russ. Next page. Which again, then comes with the long-term gain. Privileging for us now looks like this. Here's your core privileges. And like what Russ said, there's this additional line item here. Point of care ultrasonography. And under there, it says must apply using radiology special procedure list, which makes it seem like it's going to be something super big. But next. So again, core privileges, it's like what Russ mentioned. He can do a thoracotomy. He can't do an appendectomy. Next. Point of care, there it is, just a line item on there. And the next slide basically shows what it looks like. That's it. All you have to do is check that box. Point of care ultrasonography. And that's what privileging looks like. So my big takeaway from all of this is it's good to be dynamic like ultrasound. And with that, I'll open it up to the entire panel.
Great. Thank you both so much for such a wonderful and engaging talk. We're now going to move to the Q&A expert panel discussion. Please put any questions into the Q&A feature and I will relay them to the panelists. Joining Drs. Horowitz and Sharma today, we have Drs. Ruas and Vargas. Dr. J. Lauren Ruas is a neonatologist at Orlando Health Winnie Palmer Hospital for Women and Babies, where she is the Division Chief of Neonatology. Dr. Ruas founded her institution's POCUS program and is developing their neonatal hemodynamics program. She serves as a co-chair of the National Neonatal POCUS Collaborative's Program Development and Credentialing Committee. Dr. Deanna Vargas is a neonatal cardiac intensivist and the neonatal ECMO director at New York Presbyterian/Columbia University. She is a founding member of the Neonatal Heart Society and co-chairs the Program Development and Credentialing Subcommittee of the National Neonatal POCUS Collaborative. So to move on to our first question, this is for all of our panelists. how do you manage re-credentialing for providers who haven't used POCUS recently? For instance, if someone hasn't used POCUS in 1 to 2 years, do they need to repeat their original course in all scans, or do you have some way of accounting for that?
It's a really good question, actually, and something that we recently encountered when a provider who had used it then went somewhere that hadn't used it for a long time and then was coming back. Our hospital actually set a hard, fast rule that if it's been more than 2 years, you have to repeat the initial process. You can't just use the 25 maintenance scans. If you weren't using it, you can't go back and be like, hey, look, because their fear was there'd be a drop off in skill set. So some of that might come from there.
Yeah, it's interesting, right? Because as attending neonatologists, we sometimes aren't putting in peripheral arterial lines for a period of time or umbilical lines for a period of time. And to my knowledge, we're not asked to re-credential in that. We haven't had that occur yet. And so I'm actually very thankful for this question because it's something that we can bring back, Monty, to our credentialing and privileging committee to try to give some guidance for that. Because I think that we don't want to be more stringent than we are for our other credentialing processes for umbilical lines. And so as an attending neonatologist prior to coming to Orlando Health, I may not have done an umbilical line for a couple of years because I wasn't needed for one. Yet when I came to this job as the primary provider, I'm now putting them in again. And my credentialing from previous was used for this job. And so I think we hopefully can find a way to be in the middle where we're not asking people to go back to fellowship and redo all of their credentialing to prove that they could do it.
Exactly.
And so, there is something with that where as we build this out, we recognize that we could be in a situation where we're more strict than we need to be because it's new and we don't want to make it harder for people. We definitely want it to be safe. And so I think there needs to be some proficiency check off before you can go back to doing it on your own. But I don't think it needs to be a complete redo, but I would defer to some of the other opinions of the panel too.
Yeah, and some of it was the core privileges versus like a line item, right? I'm hoping one day this is just a core privilege within neonatology, so it falls under what Lauren is saying, that it's like an umbilical line, right? And this came up specifically actually in the PICU that came back to the bigger group, that there was a PICU provider who had kind of bounced around, and as a result, they ran into the same thing where you're in a position where you're not using it for anything, and then you're back and you need to use it.
And I think it also goes back to the fundamentals of fellowship training, where like that may not be the scenario for an ED physician. Russ, correct me if I'm wrong, because that's the expectation and the baseline of the training, versus now the PICUs had some more training, but it's not yet completely for everyone, or it hasn't been that long. And now with NICU, we're just starting to make sure that it's incorporated to the fellowship. So it's more like that growing pain transition phase.
Yeah, to sort of combine what people are saying is, just to reinforce, for emergency medicine, POCUS has been part of their general training and usually is not a separate line item. So people who are privileged in emergency medicine, included inherent in their basic privileges is point of care. And what we've seen is vascular access, since point of care guidance has been so inherent to the training, it's not broken out as a separate one. If those issues do arise, a question I think that we can often ask is, let's take some of the other things or procedures that people do in other divisions or departments and think about how often people need to get re-privileged in those. As an example, sort of like what Lauren was saying, is that I don't do a lot of the intubations because I have trainees that I guide through doing those. But it doesn't mean that I don't know how to do that. It's sort of inherent to my own safety design and my own system that I'm going to say, if it's been a little bit of a while, maybe I should go to the OR, maybe I should take the airway course. Maybe those are things that I need to do for my own growth and development. And clearly for people who are using point of care as part of what they do, then they should become comfortable in that. And we often see courses that someone says, I do it, but not that much because of where I work. So I wanted to go back to the critical care medicine course, for an example, just to kind of brush up a little bit on some of the other features or things that are coming out. And you're right, Lauren, and the idea of if we make it so hard for people to do, then it doesn't model what other things exist in other environments. Like, no anesthesiologist has another anesthesiologist watch them intubate. no radiologist has another radiologist overread some subset of their x-rays once they've been there for a long time. And I think that's the model that we should go toward, but sometimes it takes a while to get there.
Great, thank you so much. To move on to another question. So Monti, you mentioned during the webinar that credentialing for fellows is a little bit different. How do you handle supervision of fellows during their training? Do they need to be supervised by a POCUS certified physician for all clinical scans? And then to follow on from that, what do you recommend if it's a newer program where there aren't yet any POCUS privileged neonatologists in the group? How are you doing quality assurance and credentialing?
Yeah, great question. So that is something that we initially ran into, right? Because at some point we're all on that foundation level. It's not incorporated into a core privilege at this point. So you're going to start out in a position where the hospital hasn't given you privileges, but you're building towards that. So let's take a step back. For fellows now, what we do is every 2 weeks, we have a Q&A session where we review the scans that have been done, right? Initially, for the first about 10 scans, the fellows do it with someone who has POCUS skills. After that, they're actually encouraged them to do it alone without us there, but available for support, so that they are then gaining that confidence to do it alone, right? And it's understood amongst the nursing staff that yes, the fellows are going to be doing scans. And sometimes it'll be done on babies who otherwise are doing well, right? It's with parental permission. So we work towards that, hey, look, do the scans, use the red cap, log it all in. So whenever you go somewhere else, we can print that out and provide assurance to wherever you go that, yes, these are the things that you have done. And then we can work with you, right? That support, kind of like Russ wrote me a letter that, yes, this person has done a course, he has done this many scans, we will provide you with that same amount. So that's the education level, right? So they're encouraged, and most of them within that time frame, to do scans alone or in buddies. And what I found is actually that buddy system works really well when there's two of them doing it together. I think there's just better oh yeah, why don't you try it this way or that way? And that kind of sharing of thoughts actively helps them learn a lot better. So that's what we did initially. If you don't have privileged people, I think unsiloing yourself and sometimes leveraging the fact that we work in quaternary centers can be really useful. Sometimes it requires finding a collaborator, an ally in cardiology who's like, yeah, I know you all and are not going to go overboard and I can trust you. Why don't we provide you some oversight and education on how to do this? Or in radiology, what we actually ended up leveraging was that for a lot of our trainees, and within the institution, it's encouraged to help trainees because you can put it on your bonus statement for citizenship. And that's how the radiologists actually got super involved, is that for our fellows, they could then list that person as a trainee, which was a lot of points towards citizenship to get them a bonus.
Yeah.
So you do have to look into those kind of things. I know we all hate talking about the monetary aspects and how to leverage them, but that's really what we did. And that's how we got great radiology support.
Well, it's important, right, to understand what the stakeholders need and what's driving them. I remember when I first came here at Orlando Health, the radiologists, they weren't a part of Orlando Health at the time. And they said, to be honest, if you're asking us to do more without their private practice group, without reimbursement, how are we going to get paid to read these studies? Ultimately, once they become part of Orlando Health, then they had a different driving mechanism. And so that now they, said, yes, it's part of our citizenship that we want to be a part of this. And so it's interesting, I appreciated that honesty. They were just letting me know, in the private practice model, what the reality is of how they spend their time, but that they want to help and they want to build, but would probably just be one radiologist that would help us. And then once they adopted into the other model, those drivers changed. And so there were more radiologists that wanted to help us. And so I think you have to think about your own institution and try not to rework it, and figure out the stakeholders and then what's driving them, and just expect that there's going to be some bumps that you may have to work around. But, ultimately, I think most people recognize how important this is.
All right. So next question is, how do you differentiate privileges and competency at your institutions?
Ooh.
Yeah.
Ooh.
Privileging and credentialing or competent? Yeah, it's a...
Ooh.
I liked the earn and learn.
Yeah, I shudder at the idea of competency because we don't use competency as a separate sort of line item in anything, usually except for medical education. And when that word is used, it is not used in its truest definition. Like, how do we know that someone's competent to do X? Well, there's a mastery learning model. That's probably the best one to say that someone's competent. I think as people start talking about privileging, credentialing, learning, who can do what, we kind of go back to all the basic stuff that we do in our practices. And that is that we trust the people based upon their training to be careful and to do things for that they feel comfortable doing and that they have some assurance they're going to do correctly. Recognize that we all live and die by the procedures and the skills that we have. If we start running into trouble, there's something really unusual, something doesn't seem like it's going right, that's usually when we stop and we start asking our friends to help us, even if what we're doing is true. Now, we do that within our own division. Something's a little funny, so I walk down to a different pod and start asking a different attending, does this sort of make sense? Sometimes we have cardiology review our EKGs. Sometimes I'll have the radiologist do another ultrasound when I'm not quite sure what it is that I'm seeing. So I think the wording is really important, and we have to remind people that this is a new process, but it has legs in a lot of other places that have done the same kind of thing before. And the same rules should apply for this as apply for other things that we ordinarily do within our own institution, within our scope of practice.
Yeah, this has come up in our privileging and credentialing meetings of, nobody really likes the idea of a number because a number doesn't show competency. However, talking to one of our ER colleagues said that, when they were going through this in the very beginning, really hospitals like a number, something that would say that you've checked off, but that doesn't mean that you're competent. That means that you went through the number. And so ultimately we've settled on the number with the recognition that each individual institution and whoever is signing you off, they're really the ones that are saying that you went through their program, you satisfied what you think they need to do to be competent. But competency in itself is not something that we plan on writing out really in the privileging and credentialing, because it's so nuanced, and we do recognize that a number in of itself doesn't say competency. So we're, when we put this out, we'll have to have some disclaimers in there about that, but that's kind of where we are landing on it.
Yeah, I think it's the flexibility end of it, right? You have to be flexible and work with your system as a whole. What different systems require will be different. And you could even throw the dictionary of things at them and they're going to say, nope, for us, this is where it falls. And you have to be flexible with that. Otherwise, you're going to meet more and more roadblocks from them. Because in my mind, you could do 10 high quality scans of really high quality and be better than the person who's done 50 scans, right? Because there's no way to know the difference between that. I know one of the things that comes up is, well, you have numbers in all of these things. Well, we have to, again, for the administrative moving forward and need some numbers. We've given some numbers that might seem lower than what other fields are using, but it's partly because of what we see might be lower, right? Like we're differentiating RDS versus TTN, right? Like that's like a yes RDS, no RDS, yes TTN, no TTN. It's not like, hey, is this a pneumonia? Is this atelectasis? Is this heart failure? It's not like you have a much larger set of things.
Maybe going to develop BPD, should I put them in a trial? It's a yes, no answer.
Exactly. Yeah. So that's why the numbers for some of these things are less. However, for other things like, hey, we need to precisely measure excursion or thickening fraction and things like that, things that are more objective, the number we would say to become better at them would be higher. But again, hospitals might feel differently, right? So you have to be somewhat flexible. So that's, I think, Lauren and Deanna are also on that credentialing committee for this collaborative. And these are conversations we've had with every system that we have slogged through so far is what do we suggest to people?
And I think that's the underwritten component of, for example, the pathways that you show, where there is a program director vouching for you. It's that process where you go from individual observation to determine this person needed more intubations than another person to become proficient at intubation. And that number is so variable and individualized, but that's what that component is included in the didactics, but also kind of walking the walk with that person and understanding what the level has become. And by the time they are providing that letter, that's sort of written in that.
And there's some trust to this from the institution too, right? Like you're working that, hey, look, I know I have privileges to these things, but if I don't feel comfortable, I'm not going to do it, right? Like a part of my core privileges are doing circumcisions. I haven't done one in like 4 years. I'm not going to do one.
Yeah, I laugh because that's also part of my core privileges, but I have not done a circumcision in a very long time. And to the point, I mean, that's really where the trust comes in. So it does kind of put it back on the program director or the POCUS director to be able to say that you feel confident that this person has gone through whatever rigor that you have outlined for them and you have seen them. And then the numbers are the bare minimum, right? Because we want it to be achievable. We want there to be a bare minimal number, but we recognize that certain institutions are going to have a higher number for different things. And certain people that are going through it, all learners are different, are going to have to do more in order to get checked off. And so just because that's the baseline, that doesn't mean that's the maximum number that people are going to have to do. And so it does go back to the POCUS director or whoever's reviewing the images to say, look, I just don't think you're ready yet. And so I don't feel comfortable signing this. I need you to go back and do more. And some recognition and trust between the learner and the director, but also trust between the director and the hospital that you're not signing off anyone that you don't think is ready.
And that's really important because some of these people, like I think a lot of the people who are coming to this, are coming at the ground level at this point, right? So you'll be in the same position and you're vouching for people not just within your hospital, also for people that are then leaving your hospital and potentially going somewhere else. So it's really important to be honest. It's not an easy conversation to say, hey, yeah, I don't think you're quite ready to do this. Why don't we work on thing X, Y, and Z before we set you loose on the world?
Right. So in keeping with this conversation on numbers needed to credential, how did you pick the specific numbers needed for credentialing? As someone mentioned, they seem a little bit lower compared to the emergency medicine and pediatric emergency medicine literature.
Yeah, this is a conversation I feel like the 4 of us have had so many times, numbers, right? Like, I don't know, just as a background, we've been working on the lung credentialing one, the guidelines or whatever you want to call them. Like, how does that work from a credentialing standpoint, and the cardiac one? To simplify it right now, we've broken it between, hey, you might need this for more subjective things and this number for more objective things, right? That you need higher repetition to bring your standard deviation closer together. Our numbers specifically were driven by the group, as you saw in that step down ladder of 4 people, right? Like, hey, this seems like a safe number for these different things. But again, it's indication based, like the reason I have a person in respiratory distress is maybe a little bit more limited than what Russ might see. Or like an abdomen.
I think so the numbers are the numbers, and that makes it sort of easy and objective. Like surgeons have certain numbers, and I think proceduralists have certain numbers. We use 25 to 50, that we all recognize as slightly unusual because it had to be robust enough, but not so much that it was paralyzing to people. But we all recognize that if you're a cardiologist, you could learn a lot faster lung exam than someone who's never held a probe before. So that's where the flexibility comes into play, recognizing that learning one skill, particularly ultrasound, means that you have to do depth and gain and learn how to hold the probe and how you can do direction. But the cardiologists already know how to do that. So for them to do lung or to do abdomen is pretty easy. In addition, if you already know how to do abdomen, like in our case, we already know how to do fast. So that means kidney evaluations are pretty easy because we're already looking at those. So the flexibility of that environment, I think, is really what's necessary. And Monti nicely highlighted the idea, and we've talked a little bit about that. One thing is going to beget the next. New applications are going to arise. if you do specific individual application privileging, it's potentially fraught with peril because we almost don't imagine what is going to come out next. And if we say you got to do 50 X's, but you've already done 5,000 other ones, does Monti have to go through another 50 to do neonatal heads because that's a new application? That doesn't seem to make sense. So that's why some will advocate for the grand POCUS privileging, recognizing that that person's going to learn toward getting to their place.
I think that is actually one of the things I learned through this process of building it from where to not having anything to then having this institutional framework is privileging. You really do want to try to keep it as simple as possible, i.e. a line item or a core, if you can get it pulled into a core privilege, because it makes it more dynamic. As new applications come forward, you don't have to work with the entire set of lawyers and everything to work on privileging, because ultimately, and this isn't a part of this topic, as Russ had mentioned, privileging is what allows you to eventually bill for things. You can't bill for things that you're not privileged for technically. And so that's just kind of something to think about, is if it's easier, it's more dynamic, it's easier to change. Like only I need to make changes to the credentialing document. No one else has to do that. If I had to change privileges, that's a meeting with 30 to 40 people.
Yeah, and some of the differences we had looked at for the adult emergency medicine, it looked like some of the larger numbers were for competency over a 3-year time period and or for a dedicated fellowship. And that's not really what we're talking about at the moment. And the other reason is, what are we trying to get ultrasound used for? Crashing infant, can you quickly figure out what is killing this child? And how many scans do you need to do in order to be able to narrow it down, versus right now, if you don't have a probe, you are blindly sticking needles into different cavities, hoping that you find the fluid collection or what's going to reverse the cause. And so we wanted it to be accessible to people, safe to people, but also recognize there are certainly other applications, the ones that are more objective, that require a larger number. And so that's why you're going to see that kind of range and a lot of the things that we're talking about.
Great. Well, thank you so much, everyone. Well, we are out of time, but thank you to our speaker and panelists for this wonderful discussion, and thanks to everyone who joined us today. In the chat, you will see the link to the NeoPOCUS Collaborative website, where you can find this webinar along with all of our prior webinars. This webinar series will be taking a break over the summer, but please make sure you are subscribed to the NeoPOCUS Collab's email via the website so you receive details about the webinars and office hours this fall. Thank you all for joining today's webinar, and we look forward to seeing you in the fall.
Thank you, everybody. Have a great summer.
Yeah, happy summer.